talking about this regulatory stuff right now. How is it changing or shifting in sort of the days of COVID in order to react to, is it changing or shifting at all right
Yeah.
now?
Well, thank you for asking that. So let's just back up kind of pre-COVID, I'll say. So, for example, at the national level, at that federal level, the Centers for Medicare and Medicaid Services, who really drive Medicare coverage, which, represents a rather large portion of our population in America, those rules around how we can administer telehealth services have been pretty clamped down. They've been pretty locked down. So, for example, before COVID, we were not reimbursed to provide services to patients unless they were in a designated health professional shortage area or a very, very specific medical setting within a medical office. Now, post COVID or intra COVID, if you will, there have been some relaxation of rules. Now, I think many of us understand that these may be temporary relaxation of rules, but one of the rules that has been relaxed is that as healthcare providers, we're allowed to see patients in their residences by mobile health, mHealth, where I could be here in my home and I could be beaming Danielle Hicks up on her iPhone at her house and helping her manage her symptoms. And there's been some rule relaxation around home visits and getting people their chemotherapeutic agent infusions at home, which is really great. We can prevent interruption in healthcare delivery and important treatments, but we can also continue to connect with people. This makes so much sense, and I worry that we're going to revert back to where we were before COVID, but it's also an extremely exciting time because we're really providing a proof of concept in this country that it can be done. And if there's any silver lining from a telehealth perspective and what we're experiencing in this terrible crisis in this country, is that it's really kind of pulled the band-aid off with telehealth. And we're historically, payers, insurance companies didn't want to pay for telehealth services, and largely the concern is that the quality of care might be different, that services may not be provided to the standard of care that we would hope for or expect in person. And I think what we're going to be able to see is that the standard of care has definitely been met. We're going to have data. We're going to be able to look back and use this information, and we're going to have so many case reports and opportunities to see indeed that we can care for people, we can provide standard of care, and in many cases, we may actually be providing better care and care that is actually less costly. So I talked about the reimbursement for services that are provided in the home. There's been some relaxation in the licensure and licensed independent practitioners like myself, so doctors, nurse practitioners, physician assistants providing healthcare services across state lines. Now, there have also been rules, historical rules in other states that have said, I'll use Alaska as an example, who have a rule that says that I can't see patients in Alaska from Washington unless I've established care with that patient face to face in my office that has an Alaska address. So that instantly determines that even if Danielle Hicks comes to Seattle and has a surgery with me and goes back home, I can't really legitimately provide her services unless I have an office in Alaska and we met in person. So there are rules in this country that have been relaxed in regards to that. And that means that no prior existing relationship in person needed to be established, and I don't necessarily need to have a practice in Alaska. So you can see how advantageous that could be for various reasons across the care continuum. Within the space of lung cancer screening, diagnosis of lung cancer, depending on what diagnostic services you need, treatment of lung cancer, including surgical interventions and medical oncology, and beyond.